focus to the metastatic setting, and I will be reviewing endocrine therapy for advanced breast cancer. We'll talk about current and future strategies. So as we start the discussion, I think it's worthwhile to just review some basic information on hormone receptor signaling and the mechanisms of action of approved drugs targeting the estrogen receptor. So remember, the hormone receptor signaling is based on these three units: the activating function domain, the DNA binding domain, and the ligand binding domain. And when these three units are complexed together with HSP90, it maintains the receptor in an off state. So in the situation where estradiol binds to the ligand binding domain, it triggers release from HSP90, receptor dimerization, and DNA engagement, which then causes a coordinated recruitment of cofactors and transcriptional machinery that drives gene expression changes. So, okay, how does that translate into clinic, right? So we have several therapies that are available to treat ER-positive disease. We have aromatase inhibitors, which decrease the peripheral conversion of the male hormone testosterone to estrogen by inhibiting this enzyme aromatase. We have serum estrogen receptor modulators like tamoxifen, and then we have SERDs, and we have some exciting news with a new oral SERD that was recently approved, and I'll take you through some of that data. Of course, we also have the intramuscular SERD, fulvestrant. So these agents are really helpful and have been utilized, as we heard, in the adjuvant setting, aromatase inhibitors and tamoxifen. Of course, we don't have an adjuvant approval for fulvestrant, but they're also utilized in the metastatic setting and have been for many years very effectively for many of our patients. But there are limitations of these therapies. With aromatase inhibitors, we know under the selection pressure of aromatase inhibitors, mutations in the estrogen receptor can develop. And these drugs also confer AF2 activity in the absence of estrogen. And of course, we also are very well aware of the toxicity profile of these drugs. Our patients complain of arthralgias and not feeling great. Tamoxifen is a drug that gets utilized quite a bit in the adjuvant setting. In the metastatic setting, we don't see as much activity, particularly in patients that have progressed on aromatase inhibitors. It's a partial ER agonist. It manifests as weaker ER suppression. And of course, there are some side effects with regards to tamoxifen that can be particularly worrisome and even life-threatening, including venous thromboembolism. And then finally, fulvestrant is an agent that is effective but has some inconvenience in terms of the mode of administration. It's intramuscular, and we have to give multiple injections. There are loading doses that need to be given. Patients are obviously not happy about having to go through all of this. What we're finding out is in the era of CDK inhibitors, which now I'll go through some of that data, multiple studies are showing us that as a single agent, fulvestrant the responses are pretty dismal, on the order of a few months in these patients that had progressed on CDK inhibitors. And although we routinely think of fulvestrant as a very active drug in patients with ESR1 mutations, there are specific mutations in which we see resistance as detailed here, the Y537S ESR1 mutation where fulvestrant has not been shown to be active. So we have these hormonal therapies, and then now we have CDK inhibitors. And what is our standard in as of 2023? We used to have these discussions quite a bit when these drugs first were approved starting in 2015 about utilizing CDK inhibitors. Should we use them in all patients? What is the kind of balance of toxicity, benefit, financial toxicity? But I think now that kind of argument is settled, so to speak, because we have established CDK inhibitors as the gold standard in the first or second line setting for the majority of our patients. In terms of progression-free survival, we've seen very similar hazard ratios across all of the trials with all three drugs, palbociclib, ribociclib, and abemaciclib. We have seen a unique signal of overall survival benefit with ribociclib consistently demonstrated in multiple trials, and with abemaciclib in combination with fulvestrant in the second-line setting. We haven't seen that same signal with palbociclib. And another question that comes up quite a bit, especially in younger patients or patients that have a high visceral disease burden, is do we need to use chemotherapy first or even second line in those patients as opposed to using a CDK inhibitor? And we heard some really interesting data this year at San Antonio, the Right Choice trial, where first-line patients with a very heavy visceral disease burden received ribociclib and endocrine therapy as compared to chemotherapy, and we saw these patients did better on the CDK inhibitor. So I would say now it is really difficult to make a case to not give a patient a CDK inhibitor as either first or second line therapy in the metastatic setting. So I mentioned that I would be going through some of the data with regards to the survival benefits that were seen in these trials. Notice the ones that are boxed in red on the right-hand side include the Mona Lisa 2, 7, and 3 studies. All three of these trials were with ribociclib, and we saw a very consistent overall survival benefit with this agent, with abemaciclib in the second-line setting. The first-line abema trial at the interim analysis 2 was did not meet statistical significance, but it's certainly trending in a very positive way, so we have hopes that that study would also be positive at some point with longer follow-up. And as mentioned, palbociclib has not demonstrated a survival benefit. So what do we do after CDK inhibitors? Well, on the right-hand side of the slide, you see a lot of the work that has been done looking mechanistically of why these patients are becoming resistant. Is there a biomarker that we can identify going forward when a patient is becoming resistant or what developed? But in the meantime, while that work is going on in the clinic, we have decisions to make, and we sort of have to look at this as kind of illustrated on the left-hand side of this slide, where are we dealing with a tumor that is ER-dependent resistance has occurred? So it's not that the patient is not going to respond to endocrine therapy, they're just not responding to what you have them on, right? But the tumor is still endocrine sensitive, and that often develops in the setting of an ESR1 mutation, as opposed to what we see on the right panel on the left picture on this slide, ER-independent resistance, where it's really another pathway that has been upregulated that's driving this tumor. And this is, again, stated in a different way here. You see potential factors to consider. In this picture, you see that the ER pathway is still active and disease progression is due to estrogen-independent but estrogen receptor-mediated signaling, or so-called an ESR1 mutation, as the most common issue here, where that mutation in the estrogen receptor has impacted binding, and it's not that the patient may not still have some responsiveness to endocrine therapy, it's just not the therapy that you have them on. So how are these mutations manifesting? Well, many of them, most of them, as you see, develop in the metastatic setting under the selection pressure of exposure to aromatase inhibitors. So here you see a table where many of these studies in the metastatic setting have shown that an ESR1 mutation can be present in as high as 40% of cases, but in the primary setting, it's quite rare. So these mutations are highly enriched in the metastatic setting. Hot off the presses, earlier this year, we got an approval finally for an oral SERD, elacestrant, based on the phase 3 Emerald trial, which I will be going through with you. So as of January, this agent is approved. So oral SERDs are something that we have been waiting for a long time. As I mentioned, fulvestrant is a drug that's inconvenient in terms of dosing, and we've seen limited activity. We've had some negative data with these trials. Those are summarized on the right-hand side of the slide, AMEERA-3 and Acelera, with amnicestrant, where that drug is no longer in development, and giredestrant, where there are still studies going on with this therapy. These were negative trials. On the far left, you see the Emerald trial, which was our phase 3 large study that did lead to the approval of elacestrant as an available oral SERD. We also saw a phase 2 study presented at San Antonio recently with camizestrant. Important to recognize that these trials did have differences in terms of their inclusion criteria, and what I will keep driving home is in the Emerald trial, 100% of these patients had had a prior CDK inhibitor. In the Serena-2 study with camizestrant, we saw a good percentage, but not all, that had prior CDK, and they also have some differences in their prior exposures to fulvestrant. So those things can, of course, impact the results that we're seeing. So let's go through the Emerald trial. This was a study that was really a second and third line study, meaning these patients they had progressed or relapsed on after 1 or 2 lines of endocrine therapy for advanced disease, one of which had to be with the CDK inhibitor. So all these patients, these are really reflective of the patients that we see in clinic, and they were randomized to elacestrant, the oral SERD, or endocrine monotherapy of investigator's choice. You couldn't have progressed on fulvestrant and gotten fulvestrant if you were randomized to this arm of the study. So you had to receive something that you hadn't progressed on, and the majority of patients did receive fulvestrant if they were randomized to that arm. Notice that the primary endpoint was PFS in the ESR1 mutated patients. So this study was really powered to look at the benefit of this agent in the ESR1 mutated patients, which is different than some of the negative trials that I showed you in that table before, where the intent to treat population was what was the primary endpoint. And I think when you look at those studies and look at the ESR1 mutated patients, you see some trends of signals of benefits in those trials that were ultimately reported as negative, and this highlights the importance of powering a study to look at the population that you're most interested in. So here we saw, again, in terms of the demographics, these were patients with a high visceral disease burden. They had had multiple lines of prior endocrine therapy. About a quarter of them had had a prior line of chemo, and 100% prior CDK4/6 inhibitor. When the data was first presented, the magnitude of benefit was very small, and everyone was kind of scratching their head and saying, well, you know, this drug is expensive, and there's some issue of how are we going to put this into practice in clinic. And then last year at San Antonio, we saw an analysis that I think was really informative to help us understand how we can use this in clinic, because they broke down the PFS by duration of prior CDK4/6 inhibitor use. And it's kind of a surrogate for endocrine sensitivity. So it's very intuitive, but it was nice to see this analysis done. And what we saw in patients that in all patients, as well as those who had an ESR1 mutation, that the hazard ratios were relatively similar in those who had received at least 6 months of a CDK inhibitor. So again, bringing this into clinic, if you have a patient that has had a good response to a CDK inhibitor, this is a drug where you are seeing some clinically meaningful efficacy. The patients with endocrine sensitive disease had a remarkable PFS with elacestrant alone, and the benefit was more marked in the ESR1 mutated population, and that's where the indication for this agent is, in the ESR1 mutated patients. Of course, we want to know if this therapy has activity in combination with other agents, including other targeted agents, and that's the subject of the ongoing Elevate trial. I mentioned that there was data presented with camizestrant. This was a phase 2 study presented at San Antonio, again looking at a few different doses of camizestrant versus fulvestrant in patients that the demographics are summarized for you here. There was a bit of an imbalance with more liver metastases in the fulvestrant group and more ESR1 mutated patients in the fulvestrant group. You see their prior treatments, and what the study showed was that the primary endpoint of PFS was met in the 2 arms that included camizestrant. You see a PFS of around 7 months as compared to about 3 months with fulvestrant. And there was some discordance in investigator reported PFS, which I think remains to be further clarified. So the investigators also did important sub-analyses looking at prior CDK4/6 inhibitor use in the ESR1 mutated patients and in those with liver and lung metastases. And what we saw very consistently in all of those groups was still this benefit to camizestrant as compared to fulvestrant at the 2 different doses, which didn't seem to be any different. As far as safety, this drug has a unique toxicity of photopsia, which is seeing flashing lights and some sinus bradycardia, some fatigue, AST, ALT elevations, and we are waiting to see phase 3 data with the dose that's moving forward shown here. So in putting these 2 data sets together, I caution you not to make any assumptions about which SERD is looking better, because from a numerical standpoint, you see numbers that are higher in the SERENA-2 study, but remember it was a phase 2 study. We had a different population. About 50% of these patients had a prior CDK inhibitor as opposed to an EMERALD, where 100% had a little bit more chemotherapy prior use, so a more heavily treated population. And so this is something that, of course, it will be good for our patients to have options if we get another oral SERD, but as of now, we have elacestrant available. There are other agents besides these 2 that are under investigation. Here we see some data with imlunestrant. This agent did have some activity as a monotherapy, PFS and second-line post-CDK4/6 inhibitors. It was about 6 months, and on the bottom you see some data with imlunestrant and abemaciclib that was presented by Komal Javeri last year at San Antonio, looking at that 12-month PFS of 80% being quite high. So certainly another oral SERD that we are going to be watching closely. And there are more. There are large phase 3 studies that are ongoing. They're summarized here for you. So the take-home point is that these drugs are eventually going to make it into the clinic beyond elacestrant. And what we will be challenged to do is understand how to sequence therapies and understand patient populations that may be appropriate to receive these agents as monotherapy or in combination. So now let's go to the other aspect of endocrine resistance. We talked about that first part where it was still an endocrine sensitive tumor, but just not sensitive to what you were treating the patient with. But here in another aspect of endocrine resistance is this upregulation of other pathways. So even if you have a drug that fully suppresses ER signaling, if the tumor is relying on a different pathway, those therapies are not going to be as effective, right? So that's where we have to target those other pathways. This is a busy slide, but it just makes the point that there are a lot of targeted therapies that are under investigation. You see the signaling pathways are very complex. We have an mTOR inhibitor available in clinic, everolimus. We have an isoform-specific PI3 kinase inhibitor, alpelisib, available, but otherwise all of these other agents are under investigation. So I mentioned everolimus. We are all familiar with these data. The Bolero-2 study showed efficacy in combination with exemestane and showed a progression-free survival benefit. There's also data with tamoxifen and everolimus and fulvestrant and everolimus. So certainly a therapy that we're all familiar with, as this agent was one of our first targeted drugs as opposed to CDK inhibitors as well. Those 2 were the ones that we had available for the longest. And then more recently in 2019, alpelisib was approved. This is for patients that have a PIK3CA mutation based on the SOLAR-1 trial, where we saw an improvement that is 11 months with alpelisib fulvestrant versus 5.7 months with fulvestrant. Remember, about 40% of patients have, or tumors harbor, a PIK3CA mutation. It's interesting that in clinic we don't really see PFS that's on the order of what we saw in SOLAR-1, because those patients, very few of them had actually had a CDK inhibitor. Fortunately, the BYLieve trial, there was a cohort that did have CDK inhibitors, and we saw about a 7-month improvement with alpelisib, which is more what we see in clinic. The tough thing about this drug is the toxicity, right? So hyperglycemia, rash, diarrhea. We're learning to manage toxicity with this agent, but it's certainly a challenge with discontinuation rates that are quite high. And then, of course, there are other pathways that have been targeted, including AKT. We know that AKT signaling is implicated in the development of endocrine therapy resistance. Capivasertib is a potent selective inhibitor of all 3 AKT isoforms. And in a prior smaller study, phase 2 trial, the FACTION trial, adding capivasertib to fulvestrant in postmenopausal women with AI-resistant disease who had not seen a prior CDK inhibitor improved progression-free and overall survival. Most of the benefit there was in the altered population. So with that as background, the Capitello 291 trial was presented at San Antonio. This was a study that was looking at patients that had received capivasertib plus fulvestrant or placebo plus fulvestrant. I'll call to your attention that these patients were allowed on if their hemoglobin A1C was less than 8, and even if they were diabetic but didn't require insulin. And that is really important because when we look at toxicity profile of this drug as compared to what we know with alpelisib, these patients had higher blood sugars going in. They had 2 or fewer prior lines of endocrine therapy and were allowed to have a line of chemotherapy for advanced disease. In terms of the altered versus non-altered populations, about 40% of patients in both arms had an alteration of some sort. The demographics are summarized on the bottom for you, and the primary endpoint was PFS. These are the pathway alterations broken down. I won't go through this in a lot of detail. All I will point out is in the non-altered group, there were about 14 to 16% of patients where the answer was that it was unknown, right? So those patients that were unknown were considered in the non-altered population. And here, in terms of the primary endpoint, PFS in the overall population, as well as the AKT altered population, we saw an improvement. The PFS was about 7 months versus around 3.5 months or 3 months in the placebo fulvestrant group. Again, in terms of toxicity, we saw some discontinuations, dose reductions, but despite having that higher blood sugar allowance, these patients had hyperglycemia grade 3, only 2.3%, which is a lot better than what we're seeing with alpelisib, and grade 3 rash, 12%. So certainly a drug that, if it does become available, may be a bit better tolerated. There was an exploratory analysis of looking at PFS in the non-altered population. Again, remember, these include the unknown, so as we get more information later, maybe we will see that there isn't a benefit in the non-altered, but as of now, there seems to be a benefit even in the non-altered group. So again, how does that translate into clinic? Well, it would be great to have a drug that seems reasonably well tolerated, where we don't have to check for alteration status if it works in both. Survival is immature. Safety, I've commented on. You see the AEs leading to discontinuation were 9.3% versus 0.6%. Interruptions and dose reductions are shown as well. So certainly a therapy that we're hoping to have available at some point in the near future. And then in the last 7 minutes that I have left, I do want to rapidly take you through, even further therapies that may be on the horizon. And what you'll notice is this is a very busy slide. We go through aromatase inhibitors, SERMs, SERDs. We've done a lot of that. Then it sort of becomes like a word salad: SERCAs, PROTACs, CERANs, and all of these agents. It's just remarkable to see the progress that we're making in sort of kicking that can that is chemotherapy as far down the road as we can for these patients, right? Because the goal is to avoid the use of chemotherapy for as long as possible, maximize the time that they're on therapy that is oral and hopefully is better tolerated, which is something that we have to take into account when we look at the toxicity profiles of a lot of these targeted therapies. So Protac, the ARV-471 agent, this is a drug that I'll show you some phase 1 data in heavily pretreated population of patients that had received CDK inhibitors, 3 prior lines of therapy in any setting, and you see the clinical benefit rate of 38%, 51% in ESR1 mutated patients, median PFS. It doesn't sound impressive, but remember, these patients have gone through a long duration of CDK inhibitors and other therapies, that if we get drugs that are clinically active in this setting that can buy people a few more months of good quality of life, I think that's really clinically meaningful. There is a phase 3 trial that's ongoing, Veritac, with ARV-471 in combination with palbociclib. SERCAs are drugs that have they target a unique cysteine and ER not conserved in other nuclear hormone receptors, and there is an agent, H3B6545, that's a first-in-class SERCA and appears to have some activity in combination with palbo. Here's phase 1 data of this agent, again, heavily pretreated patients, a majority of whom had seen prior CDK inhibitors, prior fulvestrant, even some prior chemo, and you see some clinical activity, overall response rate still in the double digits, which I think, just taking a step back, what is your expectation of any activity of any therapy in this setting? It's pretty low. So to see these drugs have a clinical benefit rate of 40%, I think that's clinically meaningful. What's unique here is I mentioned that one resistant ESR1 mutation, the Y537S. Here there seems to be some activity even in that mutation. There was asymptomatic sinus bradycardia and QT prolongation. So again, bringing up this point of our tolerability of these therapies. Serans are complete ER antagonists. Remember, tamoxifen shuts down just AF2 but allows AF1 activation. This shuts down both AF1 and AF2. And OP-1250, this is an agent that is in this class, also showed a durable clinical benefit in heavily pretreated HR-positive, HER2-negative metastatic breast cancer in a small number of patients that had had multiple prior treatments, as detailed here. Clinical benefit rate here, again, was 46% and seems to be reasonably well tolerated. And believe it or not, there's more. So Serans, Protacs, all of these agents, and now we have to add on other endocrine targeting therapies like androgen receptor modulators, so SARMs, enobosarm. This is an agent that here at MCI we had the phase 3 ARTEST trial open with this therapy. It's recently been closed by the sponsor. The drug is still in development and has fast track designation by the FDA. Another really important and exciting agent to watch in this space is lasofoxifene. It's a novel SERM. It's shown activity, and the ongoing studies called ELAINE are studies to watch. We're hoping to open one of these at MCI as well. I love this slide because it makes me so excited about the progress that we finally made in breast cancer. We were always watching our lung cancer colleagues have all these mutations that they were doing all this fancy stuff with, and we were just making decisions based on how long people responded to CDK inhibitors, where their disease burden was, what their preferences were, and now we can finally show a complicated slide that shows a lot of mutations. So this speaks to the era of precision medicine. It's upon us, and it's finally come into the decision making for our patients with ER-positive disease. So here we have that standard AI and CDK inhibitor. Remember, don't forget about BRCA. We talked a lot about it in the early stage setting. We have 2 PARP inhibitors available in the metastatic setting for patients with a germline BRCA mutation. For PIK3CA mutation patients, alpelisib and fulvestrant. We are hopefully going to have capivasertib soon, maybe later this year or hopefully within the next year or so. Whether or not we're going to have to check for alteration status is something that remains to be seen, but certainly we'll have that therapy as well. Elacestrant in the ESR1 mutated patients, those endocrine sensitive patients who have done well at least 6 months on a prior CDK inhibitor. I didn't have time to go through some of the data regarding continuation of CDK inhibitors beyond progression. Kevin Kalinsky presented the MAINTAIN trial, and we did see some benefit of continuing a CDK inhibitor, and so that may be a strategy for a select patient who has a mild progression and no evidence of a RB mutation. Of course, we're waiting for the post-MONARCH trial, other larger studies that will validate that approach. And remember, we still have everolimus and endocrine therapy in those who do not have a mutation. If there's imminent organ failure, chemotherapy is certainly still in the mix. Our challenge is to understand how to selectively utilize these therapies, how to sequence them, and understanding mechanisms of resistance. And I have 28 seconds and I finished on time. Okay. Okay, so I think we are at a break. So we have a break. We have a chance to mingle with the exhibitors. Thank you for your support.